Hi, welcome back. This is sort of I consider to be the first of a two-part series. We're going to talk about adverse events, do some review of definitions and some things like that, and then we'll talk about reporting safety things like adverse events. And before I get into this, I want to tell you and just give you a sense of perspective about adverse events and how they'll work. You are never going to be working completely in isolation. When we get to adverse events, there oftentimes are lots of discussions about whether an event is an adverse event. If it is an adverse event, what kind of adverse event is it? Is it associated with a study drug? Is it associated with the disease we're studying? All these kinds of things. And at first, it can feel a little overwhelming. But I want to assure you that you're going to have a lot of responsibility here, but you're also going to be working in a team. So there are going to be lots of good people you can talk to about these things, and you're going to learn a lot as you talk. Questions are good because you'll get a better and better sense about the safety profile of the drug that's being studied, the kinds of diseases that you're studying. So don't be afraid to talk and ask questions. You're going to have other research coordinators you can talk to. You're going to have an investigator or several investigators that you can collaborate with. You always have your monitor from the sponsor you can talk to. So don't let this overwhelm you, and don't make it feel intimidating, because it doesn't need to be. Okay, so here we go. Let's start with some basic definitions. Some of this is going to be review, such as in the case of adverse event. We've been talking about these for ages now. As a reminder, it's any untoward medical occurrence associated with the use of a drug in humans, whether or not related to the drug. So it's any untoward event that happens while that person's on study. It is either, if the person comes on study and they have an existing baseline condition, it's a worsening of the condition, or it's a new condition. But it doesn't matter whether it's related to the study drug or not. It's just any medical occurrence, any change or worsening. That's an adverse event. An adverse reaction is a type of adverse event, and it's any adverse event caused by a drug. That's pretty straightforward. If it's caused by the drug, it's an adverse reaction. A suspected adverse reaction is a little more of a gray area. It's any AE for which there's a reasonable possibility the drug caused the adverse event. So there's a little bit of an openness to this. There's a little bit of questioning. There's basically saying there's a very strong, reasonable possibility. Like this is probably what caused it. A suspected adverse reaction causality can be changed later. But this is like we're leaning very heavily that this is an adverse reaction, but there's a chance there might be something else at play here. So let me give you sort of a visualization, so this will help you make sense of the differences between them. So here we have the world of adverse events, right? It's anything bad, if you will, any medical occurrence, it's untoward, that happens while a person is on study. They've signed the consent, they're enrolled in the study, and something happens that's an adverse event. Differently is a suspected adverse event. This is going to be a much smaller pool of adverse events. So this is an adverse event that has a very reasonable possibility that it's the study drug. And then out of that adverse reaction pool, we have a very small subset that says these are adverse events that were definitely caused by the study drug. So maybe that will help you sort of picture the frequency by which these events happen. So let's talk about unexpected events. It's any adverse event or adverse reaction not listed in the investigator brochure, or is not listed at the specificity or severity that severity that has been observed. So the investigator brochure is the adverse events listed in the adverse reactions listed in the investigator brochure are the listings to date of all of the sort of untoward medical things that have happened to people while they've been on the study. If you have an event, whether it's an adverse event or an adverse reaction that is not listed anywhere in the study brochure or the protocol or anywhere else for that matter, this is the first time it's happened, that's unexpected. There's a profile of safety risks that's in that investigator brochure, that's in the the protocol and the consent form that you give to participants, right? Here's everything we think that's going to happen. Well, obviously, if something happened that's not on the list, that is definitely unexpected. The second part's a little bit different. If you have an AE or an AR that is in the investigator brochure, but your patient's experiencing it in a more specific manner or at a worse severity that's been observed, you now have an unexpected event. So if there have been people that have developed asthma with this investigational drug, and they're listed as grade 1 respiratory problems, but your participant has developed asthma that's required him to be in the intensive care unit on a ventilator, even though that's an adverse event that's already been noticed in the investigator's brochure, if it's more severe, then that becomes unexpected. Also, if the investigator brochure is very general and very broad in its work, in its language, and the event is more specific, this is going to be some discussion with you and your investigator, because there's going to be a lot of medical and nursing decision that goes into this. But if the investigator brochure says cerebrovascular accident, which is a stroke, and you have something that's more specific than that, than a cerebrovascular accident, a different kind of neurological event that's more specific, then that becomes an unexpected event. So now you sort of understand why I gave you that little pep talk at the beginning of the lecture, that you are always going to work with other people to figure these things out. So that is an unexpected event. And I said this, if the A is experienced a specificity or severity that has not been observed, so it's worse or more specific. And there is an exclusion to this. The natural progression of the underlying disease is not unexpected. So, because I worked in oncology trials for so long, unfortunately, some patients died. And based on the types of cancer they had and the stage at which they had their cancer, this was not a surprise. That was a very natural progression of the underlying disease. If their cancer did not respond favorably to the investigational drugs, sometimes they would progress and die. So that was not an unexpected event. And this will, if you work with studies in which there are terminal illnesses involved, this will usually be written very clearly in your protocol, and you'll have language that explains to you that you don't have to report it as an unexpected event. So I just mentioned death, so let's talk about serious adverse events, which we know as SAEs. So an SAE is any adverse event which results in any of the following outcomes. Now this is without causality again. So it's any adverse event, which is death. Now that doesn't surprise too many people. Most people assume death to be a serious event, right? But that would be a serious adverse event. A life-threatening adverse event. So when I just said about the person with asthma that was on a ventilator in an intensive care unit, that would be a serious adverse event, just because it's life-threatening. The example of the asthmatic on the ventilator also would be inpatient hospitalization, which is a serious adverse event. Now this is a little tricky here. An SAE is also prolongation of hospitalization. So a patient is in the hospital for pneumonia, and the expected length of stay for that hospitalization is 5 days. The patient falls on the way to the bathroom and breaks an ankle or a hip, ends up staying in the hospital for 9 days. That is now an additional serious adverse event, and they're almost like Russian nesting dolls. You can have one adverse event that also becomes another adverse event. So the first inpatient hospitalization with pneumonia would be a serious adverse event, and then prolonging that hospitalization due to the broken bone would be another serious adverse event. A persistent or significant incapacity or substantial disruption of the ability to conduct normal life functions. So any type of sort of long-term disability is how I would describe it, or inability to conduct normal life functions. An example is if the study drug causes damage to nerves. So those tingling, right, if you remember from medical terminology, which you've probably had by now, those tingling at the tips of the fingers are paresthesias, and if they're really bad, they can prevent people from being able to button their clothes and do fine motor skill things because of the pain. So that could be a persistent, because sometimes that lasts for very long times, and sometimes it's a permanent disability. So again, this might involve some discussion with your investigator. A congenital anomaly or birth defect, and this is why studies are very, very careful about enrolling women and men with childbearing capacities. Especially for women, you do not want to expose an unborn fetus to investigational drugs. So this is why we're very, very careful about making sure pregnant women are not on study, and women who are on study use a reliable method of birth control. Now this last one's a big catch-all. Any other important medical event may be considered serious if it requires medical or surgical intervention to prevent one of the outcomes listed above. So, an allergic reaction in some people will cause angioedema, and it's a systemic kind of anaphylactic reaction where their lips will swell, their tongue will swell. Sometimes they'll have smooth muscle contraction around their trachea. This is an event that, if it's allowed to progress without intervention, can result in a life-threatening adverse event. So this would be the kind of thing that it does put the patient at immediate risk of inpatient hospitalization, life-threatening event. So that would be a serious adverse event. In the case of angioedema, when there is an anaphylactic reaction, the patient's in the clinic, there are steps that can be taken to stop that sort of process immediately. So the patient might not wind up in the hospital, but just because you made those interventions to prevent hospitalization means that that becomes serious. And again, don't worry, you are going to talk to your investigator and other research coordinators about this. These sometimes get a little bit gray, some of these things, especially the disability and this very last bullet point. So don't become overwhelmed. You will ask lots of good questions, and I'm sure you'll do a good job. So let's just, again, as a reminder, let's talk about serious versus severe. Severe is an adjective that we use to mean harsh, unnecessarily extreme, or grave. Whereas serious, now we oftentimes will use these interchangeably in everyday life, but they are not the same. In the world of a clinical research coordinator, severe can mean harsh or extreme or grave. But for a research coordinator, serious is a regulatory criteria that we just talked about, those criteria associated with events that can threaten a patient's life. So there's a little bit different. And if you ever get tripped up on this was an example that made a lot of sense to me, and I hope it will help you too. My example is a grade 3 headache is severe, but the severity alone does not qualify the headache as serious. You might feel like your world is coming to an end if you had a grade 3 headache. I hope I never have a grade 3 headache. And it just might feel horrible, but the grade 3 headache alone, not as a cluster of other symptoms, but a grade 3 headache alone does not qualify as requiring hospitalization, medical or surgical interventions to prevent a life-threatening event, any of those kinds of things. It's just a horrible headache, right? So that makes it severe, but it's not necessarily serious alone. So hopefully that will help you if you remember the headache example. So one of the things we talked about, the difference between an adverse event and an adverse reaction, is the adverse event is just something that happens while the patient's on study. The adverse reaction is an adverse event that is definitely caused by the study drug. So how do we determine the causality? How do you know that the study drug caused the adverse event? You're going to work with your investigator for this. But here's some of the clues, right, that we can associate the adverse event with the study drug. Again, these may associate it. Nothing is written in stone. Usually you have to look at a whole variety of factors, but these are really sort of strong indicators. The AE occurred in the expected time frame. So Patients, in this wild example I'm just making up off the top of my head, patients who receive a study drug on day 1 will typically have a grade 2 rash by day 5. If your patient comes back on day 5 and has a grade 2 rash, that's a really strong indicator that the drug is causing that, and that's now an adverse reaction. So when that investigator brochure is going to have a lot of information, it's going to say this is what's happened to other people who've been on the study. If you see the same thing in your participants, you really can feel strongly that the expected time frame validated the fact that that adverse event is actually an adverse reaction. The absence of the AE prior to the study drug. So with the asthma example, if the participant had no history of asthma, had a really good, healthy respiratory function, and they developed asthma, that might be an indicator, that's a pretty strong clue that the study drug might have caused the asthma. A positive D challenge or re-challenge. And what I mean by that is that if you take the patient off the investigational drug, that's a D challenge. The adverse event goes away, that's a pretty good clue. But the best clue is that once the adverse event goes away, you reintroduce the study drug and the adverse event comes back, that's the re-challenge. You reintroduce the study drug. That is very telling that the adverse event was caused by the study drug. The adverse event is consistent with the study drug. So my example of the rash, I had a study like that one time by week 2, so about day 15, participants had a very characteristic grade 2 rash, and there really was that, most people got that rash, right? So when the patient comes back on day 15 and they have like a grade 1, grade 2 rash, I'm going to say that's probably the study drug. Now the adverse event is consistent with a larger class of drugs. So we know different classes of drugs cause different adverse events. So if that investigational drug has a mechanism of action that is very similar to the class of drugs it belongs to, you can pretty much reliably anticipate certain adverse events. And then this last one, the absence of other causes. And this is really good. Your investigator is really going to determine the causality. You're not going to have to do that, but you're going to have to be helpful with things. The absence of other causes. Sometimes you just scratch your head and you think, I can't imagine any other reason why this adverse event is happening if it's not from the study drug. And that's sort of like an open-ended question. But your investigator might say, you know what, I have no other reasonable explanation, so I believe that this adverse event is caused by the study drug. But your investigator will work really hard to come up with very good explanations. But these are some of the things that do help. These are some of the clues that help him or her to determine whether it's an adverse event or an adverse reaction. So next week we're going to talk about how these events are reported. In the meantime, here are the references, and you know I love questions, so feel free to drop me a line or call me or whatever works for you. And otherwise, I will talk to you soon. Take care.